Hello everyone. Welcome to Global Health Education and Innovative Learning Forum channel. Myself Yuvarajan Subramaniam. Psoriasis has an unpredictable course of symptoms, several external triggers, and significant comorbidities, including arthritis, cardiovascular diseases, metabolic syndrome, inflammatory bowel disease, and depression. This video session on psoriasis brings the public health impact of psoriasis into focus. In this session, various topics will be discussed to help raise awareness of the range of ways that psoriasis can affect people's lives. The intent to empower health system with practical solutions to improve the healthcare and social inclusion of people living with psoriasis in their populations. This video session also highlights that much of the suffering caused by this common and complex disease can be avoided. Improving access to early diagnosis and appropriate treatment for psoriasis requires universally accessible healthcare systems that provide people-centered care for patients with complex, lifelong conditions. Governments and other partners have a key role to play in addressing the unnecessary social consequences of psoriasis by challenging the myths and behaviors that lead to the exclusion of patients from healthcare settings and daily life. In this session, I would like to discuss about the common myths about psoriasis, global burden and key facts on psoriasis. What is psoriasis? How does psoriasis affect people's lives and how psoriasis occurs? The synopsis on psoriasis as a chronic disease with a high comorbidity. The impact of psoriasis. What causes psoriasis and what are the common symptoms? Types of psoriasis and its associated diseases. The impact of psychological and mental health due to psoriasis. Improving the quality of care for people with psoriasis. Treating the skin manifestations and the overall recommendations to improve the services. Let us start the session. Common myths about psoriasis. Psoriasis is a skin disease. Symptoms of psoriasis are mostly visible on the skin. However, psoriasis is not only a skin condition. Psoriasis is a severe, chronic non-communicable disease. Psoriasis is contagious. Psoriasis is highly visible, but not contagious. It is not transmittable to from another person by touch or close contact. Psoriasis is caused by poor hygiene. Psoriasis has nothing to do with poor hygiene. Among the factors that affect the onset of psoriasis are genetics, the immune system, or external factors, stress, infection, skin injury, some medications, etc. Psoriasis is easy to diagnose. Many conditions that affect the skin look alike. For example, early symptoms of psoriasis can look the same as eczema or atopic dermatitis. This sometimes hinders diagnosis. Psoriasis only affects people physically. Aside from the physical burden, psoriasis brings a strong emotional, social, and economic impact. People with psoriasis often experience stigma, discrimination, and exclusion. Psoriasis imposes low costs on people and society. Often, the economic impact of psoriasis increases with psoriasis severity. Severe psoriasis symptoms can force people to stay home from work or school. Also, medication for treating psoriasis can be expensive or not covered by health insurance, causing high out-of-pocket expenses for people with psoriasis. Psoriasis treatments can both require a lot of effort and be time-consuming. Global burden of psoriasis. Psoriasis is a severe chronic, non-communicable, disabling, disfiguring and painful disease for which there is no cure. It affects over 125 million people around the world, or nearly 3% of the world's population. Due to its complexity and impact, psoriasis is considered alongside other non-communicable diseases by World Health Organization and reflected on when discussing the management of non-communicable diseases. People with psoriasis are at a greater risk of developing non-communicable disease comorbidities, such as psoriatic arthritis, which is affecting around 30% of people with psoriasis, diabetes, cardiovascular diseases, Crohn's disease, depression, cancer, metabolic syndrome, and more. Diabetes and cardiovascular diseases are among the most severe psoriasis comorbidities. At the same time, diabetes and cardiovascular diseases are 2 out of the 4 main non-communicable diseases listed in the Global Action Plan for the Prevention and Control of Non-Communicable Diseases, together with cancer and chronic respiratory diseases. Due to the risk of comorbidities, it is essential that psoriasis is addressed early, closely, holistically, and efficiently. Below are examples on the connection between psoriasis and diabetes and cardiovascular disease, but the list is not exhaustive. Psoriasis and diabetes. People with severe psoriasis face a 46% higher risk of developing type 2 diabetes. Because of this, it is recommended that people with psoriasis be screened regularly for diabetes, especially if their psoriasis is severe. Psoriasis and cardiovascular diseases. People with severe psoriasis are 58% more likely to have a major cardiac event. Treating the disease, regular screening, and good lifestyle choices are prerequisites to reduce the risk of heart attack. Recent research also reflects on the connection between psoriasis and cancer and psoriasis and chronic respiratory diseases. Studies are showing an increased risk among people with psoriasis for developing certain types of cancer, such as lung cancer, lymphoma, and non-melanoma skin cancer, as well as increased risk for developing COPD, which means chronic obstructive pulmonary disease. Key facts on psoriasis. Psoriasis is not contagious or infectious, it is a long-term skin inflammatory disease. Psoriasis mostly affects scalp, elbows, and knees but may also affect soles of feet, palms, and torso. It is an immune-mediated skin disease where the body starts making new skin cells rapidly in days rather than in weeks. Anyone at any age may develop psoriasis. However, it is more likely to appear between 50 to 35 years of age. Men and women are at equal risk of developing it. Psoriasis is a lifetime disease with periods of flare-up and remissions of the symptoms. The length of flare-ups may differ with periods of remission in between. Remission periods may vary from 1 to 12 months. Between these periods, the symptoms clear up. Prediction of periods of flare-up and remission is a challenge. What is psoriasis? Psoriasis is a chronic, non-communicable, painful, disfiguring and disabling disease for which there is no cure and with great negative impact on patients' quality of life, GHEIL. It can occur at any age and is most common in the age group 50 to 69. The reported prevalence of psoriasis in countries ranges between 0.09% and 11.4%, making psoriasis a serious global problem. The etiology of psoriasis remains unclear, although there is evidence for genetic predisposition. The role of the immune system in psoriasis causation is also a major topic of research. Although there is a suggestion that psoriasis could be an autoimmune disease, no autoantigen that could be responsible has been defined yet. Psoriasis can also be provoked by external and internal triggers, including mild trauma, sunburn, infections, systemic drugs, and stress. How does psoriasis affect people's lives? Psoriasis is a chronic, non-communicable, painful, disfiguring and disabling disease for which there is no cure, presenting without a single, typical clinical picture. It can manifest in many different forms. It is a skin disorder that causes skin cells to multiply up to 10 times faster than normal. This makes the skin build up into bumpy red patches covered with white scales. They can grow anywhere, but most appear on the scalp, elbows, knees, and lower back. Psoriasis cannot be passed from person to person. It does sometimes happen in members of the same family. In addition to the involvement of skin and nails, inflammatory arthritis, that is, psoriatic arthritis, may develop. Patients suffering from psoriasis are at higher risk of developing cardiovascular and other non-communicable diseases. Moreover, psoriasis affects mental health, and people suffering from the disease experience significant social stigma. In assessing the severity of psoriasis, more than 40 different tools are being used. Commonly used measures for scoring the severity of psoriasis include the Psoriasis Area and Severity Index, which means PASI, and the Physician Global Assessment. Clinicians assess the severity of the disease, considering the degree of scaling, redness, thickness of the skin lesions, or the size of the BSA occupied by psoriasis. Quality of life measures are also important. How psoriasis occurs. Psoriasis is a skin condition where the changes occur in the life cycle of the skin cells due to active lymphocytes or specialized white blood cells. In general, the T cells or lymphocytes attack foreign bodies to keep our bodies healthy. In patients suffering from psoriasis, the T cells mistake healthy skin cells as foreign bodies and start attacking them. As a result, the skin cells on the surface proliferate excessively and rapidly. There is an overproduction of white blood cells, T cells, and new skin cells. The growth of the skin cells is so rapid that our body is unable to remove or shed them. The underlying extra skin cell dies on reaching the skin surface and form raised, thick and red plaques with white silvery scales. Synopsis on psoriasis as a chronic disease with a high comorbidity. Psoriasis involves the skin and nails and is associated with several comorbidities. Skin lesions are localized or generalized, mostly symmetrical, sharply demarcated, red papules and plaques, and usually covered with white or silver scales. Lesions cause itching, stinging and pain. Between 1.3% and 34.7% of individuals with psoriasis develop chronic, inflammatory arthritis, that is, psoriatic arthritis, that leads to joint deformations and disability. Between 4.2% and 69% of all patients suffering from psoriasis develop nail changes. Individuals with psoriasis are reported to be at increased risk of developing other serious clinical conditions such as cardiovascular and other non-communicable diseases. The impact of psoriasis. Psoriasis causes great physical, emotional, and social burden. Quality of life, in general, is often significantly impaired. Disfiguration, disability, and marked loss of productivity are common challenges for people with psoriasis. There is also a significant cost to mental well-being, such as higher rates of depression, leading to negative impact for individuals and society. Social exclusion, discrimination, and stigma are psychologically devastating for individuals suffering from psoriasis and their families. It is not psoriasis causing the exclusion, it is largely society's reaction to it, and this can change. Treatment of psoriasis is still based on controlling the symptoms. Topical and systemic therapies as well as phototherapy are available. In practice, a combination of these methods is often used. The need for treatment is usually lifelong and is aimed at remission. So far, there is no therapy that would give hope for a complete cure of psoriasis. Additionally, care for patients with psoriasis requires not only treating skin lesions and joint involvement, but it is also especially important to identify and manage common comorbidity that already exists or may develop, including cardiovascular and metabolic diseases as well as psychological conditions. What causes psoriasis? The cause of psoriasis is unknown. However, genetics and the immune system play a vital role in its development. Risk factors for psoriasis includes obesity. There are evidence that obesity predisposes the development of psoriasis. Nevertheless, it is not clear whether obesity precedes psoriasis or vice versa. Smoking. Smokers are at high risk of developing psoriasis. In addition, smoking makes this condition worse. Certain medications. Research has found a link between psoriasis and certain medications such as I. Beta blockers, 2. Tetracycline, 3. Non-steroidal anti-inflammatory drugs, and 4. Malaria drugs. Bacterial or fungal diseases. Patients suffering from HIV are at greater risk of psoriasis. Children with recurring infections and frequent sore throat are at higher risk. The reason behind is that frequent infections weaken the body immunity. Genetics. If you have a family history of psoriasis, you are more likely to develop it. If one of the parents has psoriasis, there is 10% chance for the child to get it. If both the parents have psoriasis, the child is at 50% of developing risk to develop this skin condition. Injury. Areas of skin that are injured or traumatized becomes sites of psoriasis. However, not everyone who has psoriasis develops it at the site of an injury. Symptoms of psoriasis. The symptoms of psoriasis vary depending on the type you have. Some common symptoms for plaque psoriasis, the most common variety of the condition, include a. Plaques of red skin often covered with silver-colored scales. These plaques may be itchy and painful, and they sometimes crack and bleed. In severe cases, the plaques will grow and merge, covering large areas. B. Disorders of the fingernails and toenails, including discoloration and pitting of the nails. The nails may also crumble or detach from the nail bed. C. Plaques of scales or crust on the scalp. People with psoriasis can also get a type of arthritis called psoriatic arthritis. It causes pain and swelling in the joints. The National Psoriasis Foundation estimates that between 10% to 30% of people with psoriasis also have psoriatic arthritis. Types of psoriasis. There are different types of psoriasis. This classification is based on the presentation and location of the disease. Here are different types of the disease. Plaque psoriasis, It is the most common type of psoriasis and is characterized by raised and patches on the skin with silvery white scales. It mostly affects knees, lower back, elbow, and scalp. The skin may crack, bleed, itch and sore. The itching is intense during the night. Scratching makes the condition worse and plaques thicker. This type of psoriasis is more common in adults. Scalp psoriasis. Scalp psoriasis affects about half of the population suffering from psoriasis. It forms white or silver and powdery flakes on the scalp. The skin of the scalp becomes crusty. Plaques may cover the whole head including the back of the neck, ears, and forehead. Guttate psoriasis. Guttate psoriasis mostly affects young adults and children. It affects 10 in every 100 patients suffering from psoriasis. It appears as small, red-colored dots with raised edges in the middle of the body. However, it also may appear on the scalp, ears, arms, legs, and face. The common trigger behind guttate psoriasis is upper respiratory tract infection, stress, skin injury, strep throat, cold, tonsillitis or flu. In addition, it may follow antimalarial treatment and the use of beta blockers. Inverse psoriasis. In inverse psoriasis, bright, shiny, red, and sore lesion forms without silver scales. Mostly the lesions appear under the skin folds such as under the breast, genitals, behind the knees, and armpits. Sweating and rubbing make the symptoms worse. Pustular psoriasis. Here red and swollen patches with bumps filled with pus are formed. With time, the pustules dry and become yellow-brown. If blisters open, the skin becomes sore and cracked. Pustular psoriasis develops due to stress, exposure to certain chemicals, certain medications, and infection. It occurs mostly on palms or the bottom of the feet. If this condition occurs along with muscle weakness, fever, chills, rapid pulse and spread quickly with severe itching, immediate hospitalization is required. Erythrodermic psoriasis. It is a life-threatening condition that requires immediate hospitalization. Symptoms include periodic and fiery red skin with a shading of the scales in sheets. Other severe symptoms are severe itching, rapid heartbeat, painful skin and feeling too hot or too cold. Erythrodermic psoriasis is triggered by severe infection, certain medications, sunburn, and withdrawal of psoriasis treatment. Psoriatic nail disease. Half of the population suffering from psoriasis develops psoriatic nail disease. The skin under the nails become thick. Yellow or brown red spots form under the nails. Nails often crack or split. Tiny dent may be present on the nail's surface. In severe condition, nail crumbles and falls. Psoriatic arthritis. About 1/3 of the population suffering from psoriasis also suffers from stiffness, swelling, and pain in the joints. If skin psoriasis and arthritis occur together, it is psoriatic arthritis. In most of the cases, the symptoms of skin psoriasis are first to come. In addition, there may be color changes and crumbling of nails. This is detailed under the autoimmune conditions with psoriatic arthritis. Psoriatic arthritis. In addition to the skin, psoriasis can be associated with an inflammatory arthritis known as psoriatic arthritis, which involves the joints of the spine and other joints. This occurs without presence of specific antibodies in the blood, that is, seronegative spondyloarthropathy. The rheumatoid factor, which means antibody occurring in rheumatoid arthritis, is also negative. Studies showed that psoriatic arthritis affects between 1.3% and 34.7% of patients diagnosed with psoriasis. The clinical symptoms are variable, however. Peripheral arthritis, spondylitis, enthesitis, which means inflammation of the sites where tendons insert into the bone, arthritis in the fingers and dactylitis, profuse swelling of the fingers or toes, are most common. Psoriatic arthritis can lead to chronic pain and change in physical appearance. Patients suffering from psoriatic arthritis have reduced physical fitness compared to psoriasis patients without it. Typically, psoriatic arthritis occurs in conjunction with long-standing skin lesions, although rarely it occurs alone, in the absence of psoriasis. Associated diseases. Numerous studies have reported the coexistence of psoriasis and other serious systemic diseases. Most often mentioned are cardiovascular diseases, metabolic syndrome, including hypertension, dyslipidemia and diabetes mellitus, and Crohn's disease. Even children show increased rates of comorbidity compared to unaffected infants, or those with atopic eczema. Patients diagnosed with psoriasis have an increased burden of subclinical atherosclerosis and vascular inflammation. They also have significantly higher levels of serum lipids, including triglycerides and total cholesterol, compared to healthy individuals. Moreover, psoriasis is associated with atrial fibrillation and stroke, which may be aggravated in young patients. However, it should be noted that at present it is not known whether psoriasis is an independent risk factor for the development of cardiovascular disease. Obesity or weight gain has been shown to be an independent risk factor for psoriasis. Tobacco smoking is another risk factor. Frequency of metabolic syndrome, depression and erectile dysfunction has also been found to be significantly higher in patients diagnosed with psoriasis. In some diseases and subgroups of patients, psoriasis has been shown to be an independent risk factor for non-alcoholic fatty liver disease. Despite a high number of studies on the association of psoriasis with comorbidity, the causality and independence on some associated diseases remain unclear and need further research. Psychological and mental health. Psoriasis is not only a disease that causes painful, debilitating, highly visible physical symptoms. It is also associated with a multitude of psychological impairments. For many reasons, psoriasis can be psychologically devastating. Patients' lives become especially difficult when psoriasis is present in highly visible areas of the skin such as the face and hands. Related psychological problems can affect everyday social activities and work. It causes embarrassment, lack of self-esteem, anxiety, and increased prevalence of depression. Patients with psoriasis report experiencing anger or helplessness, and they disclose a higher rate of suicidal ideations than other patients. Improving the quality of care for people with psoriasis. Principles of psoriasis management. Psoriasis is by nature a chronic, incurable disease with an unpredictable course of symptoms and triggers. The consequence is often lifelong treatment. Therefore, all treatments must meet high-quality criteria that are not only efficacious, but also safe over long periods. As the cause of psoriasis is still unknown, treatment is only available to control symptoms. Treatments include a range of topical and systemic therapies as well as phototherapy. It also involves treatment for reducing pain and disability from arthritis and other manifestations. care for patients with psoriasis requires more than management of the skin lesions and joint involvement. The complexity of psoriasis means that prescribing drugs in isolation is insufficient to control the disease, and a holistic, whole-person approach to care is needed. Management of psoriasis also includes screening for associated diseases such as hypertension, dyslipidemia, diabetes mellitus, and cardiovascular disorders, as well as their complications such as myocardial infarction and stroke. Psoriasis patients are more likely to suffer from depression and anxiety disorders and have an increased rate of suicidal ideation. Screening at regular intervals for these associated diseases and for co-medication to prevent drug-drug interactions or drug-triggered psoriasis, as well as recognition of trigger factors and their treatment, are an essential part of psoriasis management. Management algorithms for countries with a developed social and healthcare system can be adapted to the needs of local healthcare environments. Psychosocial interventions may be needed, such as psychological treatment, patient education, and psychotherapy. One-to-one sessions, group therapy, nursing intervention, and support by phone or telemedicine may also be helpful. Treating the skin manifestations. There are three major forms of therapy: topical therapy, phototherapy, and systemic therapy. Treatment is based on psoriasis severity at the time of presentation. Mild psoriasis usually is treated with topical therapy, progressing to phototherapy in the case of insufficient response. Moderate to severe psoriasis requires systemic therapy. Commonly used first-line drugs include methotrexate, cyclosporin, acitretin, and etretinate. In some countries, other systemic therapies such as biologic agents and fumaric acid esters are available. All treatments for psoriasis, apart from retinoids, are primarily anti-inflammatory and subsequently lead to slowed epidermal keratinocyte turnover and a flattening of plaques. In many countries, other treatments may play a prominent role, including traditional Chinese medicine, self-treatment with over-the-counter products, which means non-prescription drugs, and climatotherapy. Recommendations. The control of psoriasis and prevention of its complications require action by governments and policymakers. Furthermore, scientists, health professionals, and the associations uniting them have an important role to play in improving the GHEIL of people suffering from psoriasis. Patients' organizations, civil society, and the media are crucial in advocating for change and helping fight stigma and ignorance. Actions for governments and policymakers. Government should ensure that people suffering from psoriasis have access to professional medical care. It is essential that psoriasis is diagnosed as early as possible. Early diagnosis and appropriate therapy give the best chance to prevent patients from unnecessary suffering, uncontrolled disease, irreversible deformities of the joints, and disability. Optimum therapy also reduces mental health and societal costs of the disease. Patients suffering from psoriasis should have access to comprehensive, individually adapted treatment. At a minimum, public and private facilities should provide the drugs included on the WHO model list of essential medicines, including systemic therapies. Universal health coverage schemes should cover the costs of these treatments for newer biological therapies. More needs to be done to reduce the price of these medicines, if they are to present a sustainable and affordable treatment option for patients with psoriasis. The development of biosimilars may help in this regard. Governments should take cost-effectiveness of treatment options into account when developing national guidelines. Optimum treatment of psoriasis and its comorbidities require shifting to a model of people-centered and integrated health services, as outlined in the WHO Global Strategy on People-Centered and Integrated Health Services. All people with psoriasis should have access to health services that are provided in a way that responds to their preferences, are coordinated around their needs and are safe, effective, timely, efficient and of an acceptable quality. This is essential not just to improve the lives of people with psoriasis, but also for all other chronic complex conditions. Governments and non-governmental organizations should provide education on common chronic skin conditions to healthcare professionals, including undergraduate medical and nursing curricula and in-service training for physicians in primary care. There is a great need to raise awareness and knowledge about psoriasis among general practitioners to increase early diagnosis and prevent disability. Governments also have a role in supporting psoriasis research. Governments have a key role in reducing stigma and discrimination. Society, not psoriasis, causes the exclusion and discrimination faced by people with this disease. This situation can change through campaigns to raise awareness of psoriasis among the population and by condemning discrimination of patients who suffer from it. Actions for health systems and health professionals. All health professionals, especially clinicians working in primary health care, should be aware of psoriasis, its management, and its comorbidities. Healthcare professionals associations should provide training, for example, via the internet for physicians from low and middle income countries, regarding prompt diagnosis and effective treatment of psoriasis. Patients with psoriasis need access to primary health care that responds to their individual needs and coordinates with any additional specialist care. In settings with adequate resources, healthcare professionals and health systems must strive to provide patients with comprehensive care from multidisciplinary teams of specialists, including dermatologists, rheumatologists, psychologists, psychiatrists, pediatricians, cardiologists, and others. Clinicians must inform patients about the possible consequences of the disease and collaborate with them to identify barriers to adherence and help address these barriers to achieve optimal management. Associations of medical specialists have a role in seeking consensus on the classification of psoriasis and standardization of the collection of epidemiological data using a unified methodology. There is a great need to develop guidelines regarding the diagnosis of psoriasis and its treatment. Furthermore, certain standards relating to medical care such as adequate assessment of progress of therapy, using uniform tools to assess the severity of the disease and patient quality of life should be implemented. Doctors should establish objectives of care and plan therapy in collaboration with their patients. Actions for patients' organizations and civil society. Patients' organizations must continue advocating for the rights of individuals suffering from psoriasis. They should be involved in raising awareness of psoriasis among the population in collaboration with governments and policymakers. Patients' organizations have a key role in providing support to people suffering from psoriasis and in creating networks to foster mutual support and exchange of experiences. Patients' organizations have a responsibility to encourage the formation of patients' associations where currently none exists. Patients' organizations and civil society have a key role in holding governments and policymakers to account on global commitments, and in fighting discrimination of people with psoriasis. Priority areas for research. There are many unmet needs for psoriasis, including epidemiology, etiology, treatment and ways to improve health care. Researchers should investigate the etiology of psoriasis and therapies to prevent as well as to manage the symptoms of the disease. It is vital to create low-cost effective treatment options that can be made widely available. Research on new treatments should focus on options which can be applicable globally, on a large scale. New treatments need to be affordable, effective, and safe in the long term, stable in hot and humid climates, and require minimal monitoring. Health services research needs to be better used in identifying specific needs of healthcare, unmet patient needs, and barriers of guideline-compliant treatment. Health services research should monitor and provide feedback on the actions taken to improve quality of care and investigate efficiency of care. Psoriasis care could thus become a model for the management of other chronic skin diseases. A key area of healthcare research is the epidemiology of psoriasis and its incidence and prevalence on the global level. Research methods need to be harmonized and reflect cultural as well as geographical differences. I hope this video will be extremely useful, and thank you so much for watching this video. Kindly click the like button in case you feel useful and give your valuable comments for better improvement. Please subscribe GHEIL Forum channel and share all our video links to your friends, colleagues, people who work in the development and healthcare sectors. Once again, thank you so much.